Welcome to the Deep Dive. We're here to really boil down complex topics, get you the core knowledge you need, fast.
Exactly. Forget spending hours sifting through notes.
Today, it's all about bladder cancer. We're aiming for surgical precision here. Think of this as your super efficient revision session, hitting the key points for exams like the MSRA.
Yeah, we've taken the revision materials and distilled them right down. The goal is a clear, structured understanding.
Right. Definition, causes, risks, how it develops, what else it could be, how common it is.
How patients present, investigations, management, prognosis, and complications too.
And we'll sprinkle in memory tips and mnemonics along the way.
Should be useful.
Okay, ready to kick off with the definition. What exactly is bladder cancer?
Absolutely. Let's get straight to it. At its heart, bladder cancer is uncontrolled, abnormal cell growth.
Okay.
And it happens in the lining of the bladder. Now, what's really key, especially for exams covering developed countries, is that about 90% of these cancers start in the transitional epithelial cells.
The transitional cells.
Right. So think transitional cell carcinoma, or TCC, sometimes called urothelial carcinoma. You know, that lining, the urothelium, is always bathed in urine, which, well, can carry carcinogens.
Okay. So that makes sense. And is it just one type of growth?
No, not exactly. You tend to see two main patterns. First, there are non-invasive papillary tumors. You can picture them like little fingers growing out from the lining.
Right, projecting inwards?
Exactly. They're often easier to manage initially, but then you have the invasive solid tumors.
Interinvasive means?
It means they can push deeper into the bladder wall. And crucially, they can spread, metastasize to other parts of the body.
Okay, that's the more dangerous type.
Definitely. And there's another thing, sometimes the cancer doesn't start as those papillary growths. It can arise from flat areas of abnormal cells just within the lining itself. That's called carcinoma in situ, or CIS, often high grade.
CIS, right. So for memory, the key cell type.
Maybe think P-thelium for the epithelium where it starts, and transition for transitional cell carcinoma, the most common type.
P-thelium transition.
Got it.
Okay, moving on to etiology. What actually triggers this? Is there one specific cause?
Well, pinning down a single precise cause for any one person is often difficult, you know? But we know there are major factors that definitely increase the risk. The big three are chemical exposure, especially things called aromatic amines.
Like in industry?
Yes, exactly. Found in certain industrial processes. Then tobacco smoking, that's a huge one. And third, chronic inflammation of the bladder over a long time.
Okay, so chemicals, smoking, long-term irritation.
That's a good summary of the main players. It's thought those aromatic amines, once metabolized, can damage the DNA in the bladder lining cells.
Right, so if someone asked you, say, for a quick self-test, top 3 etiological factors.
You'd say chemical exposure, aromatic amines, smoking, and chronic bladder inflammation.
Perfect. Now let's drill down a bit more into the risk factors specifically. We've mentioned the big ones.
Yeah, let's expand on those.
Okay, so we know it's more common in men.
Yep.
And the risk goes up quite a bit with age.
Significantly, yes.
Smoking, you said 2 to 6 times the risk. That's massive.
It really is. And then occupational exposure, you mentioned industry. Things like paint, dye, metal, petroleum industries account for maybe 10% of cases.
Again, those aromatic amines.
Precisely. But there are other factors too, medical ones, like radiation therapy to the pelvis for other cancers.
Right.
Or using the chemotherapy drug cyclophosphamide.
Okay.
And that chronic inflammation we mentioned. That can come from things like recurrent bladder stones or having a catheter in long term. Constant irritation.
Makes sense. And didn't you mention something about geography earlier?
Yes. In certain parts of the world, particularly places like Egypt, there's a parasitic infection called schistosomiasis. It causes chronic bladder inflammation and is strongly linked to a different type of bladder cancer, squamous cell carcinoma, not TCC.
Interesting. So different pathway, same end result of inflammation leading to cancer.
Exactly. It highlights that inflammation link. And the gender thing, more men than women. Well, hormonal differences might play a role, but smoking rates historically were higher in men too, though that's changing. It's likely multifactorial.
Okay, that's a lot of risk factors to remember. Is there a mnemonic, maybe?
There is, actually. How about SSOCCRAGE?
SSOCCRAGE. Let's break that down.
Okay. Smoking, sex, male, occupation, chemicals, cyclophosphamide, radiation, age,
Chronic inflammation.
and geography, thinking schistosomiasis, SSOCCRAGE.
SSOCCRAGE. Smoking, sex, occupation, chemical, cyclophosphamide, radiation, age, Chronic inflammation geography. Brilliant. That should stick.
Hope so.
Okay, so we know the risks. What about the actual process? How does the cancer develop and progress? The pathophysiology.
Right. So it starts with those abnormal cells in the bladder lining, likely initiated by DNA damage from those risk factors.
Okay.
These cells then start dividing uncontrollably, forming a tumor. The really critical step is when it becomes invasive.
Meaning it breaks through.
Yes, it starts to penetrate through the layers of the bladder wall. First the lamina propria, then the muscle layer, maybe even further. And then, if those cells break off, get into the blood or lymph system, they can travel and set up shop elsewhere. That's metastasis. Lungs, liver, bone, makes things much harder to treat. And tumor grade is important here too, how abnormal the cells look. Higher grade often means more aggressive.
So it's a sequence. Abnormal cells grow, form a tumor, invade the wall, potentially spread.
That's the gist of it.
Is there a quick way to remember that progression?
Maybe something simple like grow through, go.
Grow through, go.
Grow, the initial abnormal cell growth. Grow through, invading the bladder wall. Go. Metastasizing. It emphasizes catching it early, before the go stage.
Grow through, go. Clear and memorable. Okay, now, someone comes in with symptoms, maybe blood in the urine. What else could it be besides bladder cancer? What are the differentials?
Right, really important clinically. Blood in the urine, hematuria, is common, but it doesn't always mean cancer. No. Think common things first. Urinary tract infections, UTIs, are very common causes of hematuria, often with pain, though.
Okay, UTIs.
Bladder stones can cause bleeding, too. Benign things like polyps in the bladder, not cancerous, but can bleed.
Right.
Then there's interstitial cystitis, painful bladder syndrome, hemorrhagic cystitis, which is bladder inflammation, often with bleeding, maybe after chemo or radiation.
Okay.
Kidney stones, nephrolithiasis, passing a stone can cause bleeding. And you have to consider cancer elsewhere in the urinary tract, like renal cancer, kidney cancer, or even just urethral trauma.
Quite a list. So if a patient has that classic painless hematuria, which we know is a red flag,
Yes.
what are the top couple of differentials you'd want to rule out quickly besides cancer?
Well, you definitely check for a UTI, even if painless, and consider stones. But honestly, unexplained painless hematuria, especially if they're over 60, you have to investigate thoroughly for bladder cancer. It's top of the list until proven otherwise. Absence of pain is not reassuring here.
Crucial point. Okay, let's talk numbers. Epidemiology. How common is this?
Globally, it's around the 7th most common cancer overall. 7th. Okay. In the UK, we're talking over 10,000 new cases each year.
Wow.
And like we said, more common in men, about a 3-to-1 ratio, male to female. And the vast majority, really, are diagnosed in people over 75.
Okay, so quick memory points for epidemiology. Ranks 7th over 10,000 cases a year in the UK, mostly men, mostly over 75.
Pretty much nails it.
Right. So how do patients typically present? What clinical features bring them in?
The number one symptom, far and away, is hematuria, blood in the urine.
Visible blood.
Often visible, yes. Macroscopic hematuria. And importantly, it's often painless, especially early on. That's the classic presentation.
Painless, visible hematuria.
Exactly. But patients might also have other urinary symptoms, like needing to pee more often frequency, or getting a sudden desperate need to go urgency, maybe pain or burning when they pee dysuria.
Okay.
If the disease is more advanced, they might get pain lower down, pelvic pain, back pain, abdominal pain.
And those symptoms like frequency and urgency,
Yeah.
can they happen without visible blood?
Yes, definitely. Especially with that flat type carcinoma in situ, CIS. It can cause a lot of irritation, so frequency, urgency, even pain. And an interesting point, women, when they are diagnosed, are actually more likely to have muscle-invasive disease already than men are.
Really? Why is that? Delayed diagnosis, perhaps?
Possibly. Symptoms might be initially mistaken for UTIs more often, perhaps. It's not entirely clear, but it's an observed pattern.
Okay. And when someone is diagnosed, how advanced does the cancer tend to be?
Well, the stats are roughly like this. About 5% already have metastatic disease at diagnosis, spread to lymph nodes, lungs, liver, bones, sometimes brain.
5% metastatic.
Around 30% or so have muscle-invasive disease. It's gone into the bladder muscle layer but hasn't spread distantly yet.
Okay.
And the biggest group, about 70%, have superficial disease. That includes non-invasive papillary tumors and T1 tumors, and also CIS, which makes up about 10% within that superficial group.
So most are caught before spreading widely.
Most, yes. But even microscopic hematuria, the blood you can't see, only found on a dipstick test, needs attention, especially in people over 60. NICE guidelines are very clear. That needs investigation.
Right. Don't ignore the dipstick positive.
Yeah.
Okay, so investigations. How do we confirm the diagnosis?
It's a step-by-step process. First, usually urinalysis. Check for blood. Rule out infection with a urine culture.
Standard stuff.
Yep. A full blood count, FBC, to check for anemia, maybe from chronic blood loss. Renal function tests, UNEs, to check the kidneys are working okay. Then there is urine cytology, looking for cancer cells in the urine. It can be helpful if it's positive, but a negative result doesn't rule out cancer, especially low-grade tumors. Its sensitivity isn't perfect.
Okay, so cytology isn't definitive on its own. What's next? Imaging.
Imaging comes in, yes. If you strongly suspect muscle-invasive disease up front, you might do a CT or MRI for staging before the main diagnostic procedure, which is cystoscopy. That's the gold standard. Putting a camera, a flexible scope usually, into the bladder.
Look directly inside.
Exactly. You can see any suspicious areas, tumors, lesions, and crucially, you can take biopsies right then and there.
Biopsy confirms it.
Yes. Now, in specific situations, like a tumor near the bladder neck, or if CIS is suspected, or if cytology is positive but you don't see an obvious tumor, or you see weirdness in the prostatic urethra in men, you might also biopsy the prostatic urethra.
Okay.
And one more thing, if you really suspect CIS, especially with positive cytology or recurrent high-grade tumors, sometimes fluorescence-guided biopsy is used. You instill a photosensitizing agent, and under blue light, the cancerous areas glow pink. Helps find those flat lesions.
Clever. So cystoscopy and biopsy are key for diagnosis. What about staging, figuring out how far it's spread?
Right. Staging is vital for planning treatment. For the primary tumor, the T stage, especially if considering radical treatment like removing the bladder, MRI with dynamic contrast or contrast-enhanced CT are often used to see how deep it's gone. Once muscle invasion is confirmed on biopsy, you need full staging. That typically means a CT scan of the chest, abdomen, and pelvis that looks for spread to lymph nodes or distant organs. And it usually includes CT urography, looking at the kidneys and ureters too, for other tumors.
Okay, and this is all summarized using the TNM system.
Exactly. TNM, T for tumor, N for nodes, M for metastasis.
Can you give us a quick rundown of the T stages for bladder cancer?
Sure. So T is non-invasive papillary, just on the surface. TIS is carcinoma in situ, that flat high-grade lesion. T1 means it's invaded the connective tissue just under the lining, but not the muscle yet.
Okay.
T2 means it's into the muscle layer. T2A is superficial muscle. T2B is deep muscle. T3 means it's gone through the muscle into the fat surrounding the bladder. T3A is microscopic invasion. T3B is macroscopic, visible on imaging.
Right.
And T4 means it's invaded adjacent organs, prostate, uterus, vagina, pelvic wall, abdominal wall. T4A and T4B specify which structures.
That's quite detailed for T. What about N, the lymph nodes?
N is for regional lymph nodes. N0 means no lymph node spread. N1 means spread to a single node in the true pelvis. N2 is multiple nodes in the true pelvis. N3 means it's spread to the common iliac nodes, which are higher up. And NX means nodes can't be assessed.
Okay. And M, metastasis.
M is simpler. M0 means no distant metastasis found. M1 means there is distant metastasis spread to lungs, liver, bone, etc. And MX means metastasis hasn't been assessed.
Got it. T and M. And you mentioned guidelines might refine this.
Yeah, NICE guidelines, for instance, might incorporate grade and tumor size alongside the TNM stage because those also affect prognosis and treatment decisions. And just to reiterate those referral guidelines, unexplained visible blood in urine or recurrent UTIs in someone over 60, they need an urgent urology referral. Red flags.
Absolutely. Okay, that clarifies staging. Now, the crucial part, management. How do we treat bladder cancer?
Well, it really depends heavily on the stage and grade. We usually break it down into non-invasive, invasive, meaning muscle invasive, and metastatic.
Right. Let's start with non-invasive.
Okay. For non-muscle invasive bladder cancer, NMIBC, it's all about risk stratification, low, intermediate, or high risk of recurrence and progression.
How do you treat low risk, say, a single, small, low-grade tan tumor?
Standard is TURBT transurethral resection of bladder tumor. That's where they scrape the tumor out via the cystoscope, often followed by a single dose of chemo put directly into the bladder, like mitomycin C, right after the surgery. Then surveillance cystoscopy.
Okay, what about higher risk, non-invasive, high-grade tan T1 or CIS?
That's where intravesical BCG comes in, Bacillus calmette-guerin. It's a weakened form of the TB bacterium.
It's a UD bacteria.
Exactly. Put into the bladder, it provokes a strong local immune response that attacks the cancer cells, usually given as an induction course, often followed by maintenance doses for a year or more.
BCG for high-risk NMIBC.
Yes. It's very effective for many patients, especially with CIS. But if BCG fails, or for very high-risk disease initially, radical cystectomy removing the bladder might be recommended even for non-muscle invasive disease.
Wow, removing the bladder even if it hasn't invaded muscle.
In select high-risk cases, yes, because the risk of it progressing to muscle invasive is so high. It's a balance of risks, benefits, and patient factors.
Okay. Now, what if it is muscle invasive, T2 or higher?
Right, muscle invasive bladder cancer, MIBC. Here, the standard approach, if the patient is fit enough, often involves neoadjuvant chemotherapy first.
Chemo before the main treatment.
Yes, usually cisplatin-based chemo. Giving it before surgery or radiotherapy has been shown to improve survival.
Okay, so chemo first. Then what?
Then the main treatment is usually either radical cystectomy, removing the bladder, prostituterus, and nearby lymph nodes.
Major surgery.
Yes, big operation. Can be done open or laparoscopically robotically. Or the alternative is radical radiotherapy, often given with chemotherapy drugs acting as radiosensitizers to make the radiation work better.
Surgery or radiotherapy? How do you choose?
It depends on the tumor extent, patient fitness, patient preference, potential side effects. It's a complex decision, often discussed in a multidisciplinary team meeting.
Mm-hmm. You mentioned removing the bladder.
Yeah.
What happens then?
Patients need a urinary diversion, commonly an ileal conduit, where urine drains into a bag worn on the abdomen. Or sometimes, in selected patients, an orthotopic neobladder can be created using bowel, allowing them to potentially void more naturally, though incontinence can be an issue.
Okay. Any other treatments for invasive? Adjuvant chemo?
Yes, adjuvant chemo after surgery might be used if chemo wasn't given beforehand, especially if there are high-risk features found at surgery, like positive lymph nodes. And for patients unfit for major surgery or chemo, external beam radiotherapy can be used for symptom control, palliation, sometimes even palliative cystectomy if there are severe local symptoms like bleeding.
And newer drugs. Immunotherapy.
Yes, things are evolving. Avelumab can be used as maintenance therapy after first-line chemo for advanced metastatic disease if it hasn't progressed. And nivolumab can be used as adjuvant therapy after cystectomy for high-risk MIBC, trying to reduce recurrence risk. These are important recent additions.
Good to know. Okay, finally, what about metastatic disease, stage 4?
When it's spread distantly, the goal is usually palliative, controlling the cancer, managing symptoms, prolonging life. First-line treatment for fit patients is typically cisplatin-based combination chemotherapy.
And if they can't tolerate cisplatin?
Then carboplatin-based chemo or even single agents might be used. If the cancer progresses after platinum chemo, there are second-line options, including immunotherapy agents like pembrolizumab or nivolumab in some settings, and avelumab maintenance, as we mentioned.
Okay, so chemo and immunotherapy are the mainstays for metastatic disease. And surveillance after treatment, how is that managed?
Surveillance is crucial. For non-invasive disease, it involves regular cystoscopies, the frequency depending on the risk category. Low risk might eventually be discharged. High risk needs long-term follow-up. After radical cystectomy, follow-up involves checking kidney function, monitoring the diversion, and regular imaging, like CT scans, to look for recurrence. After radical radiotherapy, follow-up includes cystoscopies to check the bladder, plus imaging and monitoring.
Right, ongoing monitoring is key. Let's talk prognosis then. What are the chances?
It really varies hugely based on stage and grade at diagnosis and response to treatment. Early detection makes a massive difference.
So for superficial, non-invasive tumors?
Prognosis is generally good. 5-year survival rates are often quoted around 80–90%. But, and it's a big but, recurrence is common, especially for high-grade superficial tumors. They need close watching.
Okay. And for muscle invasive?
It's more serious. The 5-year survival is more variable, maybe in the range of 30–60%, depending on factors like exact T-stage, node status, response to chemo.
Right.
And unfortunately, for metastatic disease, the prognosis is poor. 5-year survival is low, maybe 10–15%.
Those numbers really highlight why early diagnosis and effective treatment are so critical.
Absolutely. The key prognostic factors are tumor grade, depth of invasion, T-stage, and whether CIS is present alongside a papillary tumor.
Okay. Finally, what about complications, either from the cancer itself or the treatments?
There can be quite a few. Metastasis, obviously, is a major complication of the cancer itself. Recurrence after treatment is another big one. Treatment side effects. Well, after cystectomy, urinary incontinence or needing a stoma bag are life-changing. Erectile dysfunction in men is common after cystectomy.
Okay.
The cancer itself can block the ureters coming from the kidneys, leading to kidney damage, hydronephrosis. UTIs can be more frequent. urinary retention. There's also a risk of developing new tumors higher up in the urinary tract later on.
And surgical complications.
Standard surgical risks like infection, bleeding, bowel problems like obstruction if bowel was used for reconstruction, ureteric strictures where the ureters join the diversion or neobladder. Lots of potential things to monitor for.
A complex picture with significant potential impacts. Well, that really covers the landscape of bladder cancer, doesn't it?
I think we've hit all the key areas outlined: definition, risks, presentation, diagnosis, staging, management options for different stages, prognosis, and potential complications.
It's been a comprehensive run-through. Hopefully this focus session gives you a really solid, high-yield overview, especially if you're revising for the MSRA.
Yeah, the aim was clear, concise, and memorable information.
Definitely go back and revisit any parts you need to reinforce. And for more resources, absolutely check out passmsra.com.
And freemsra.com too. Both have great materials to help you prepare.
We really wish you the best of luck with your ongoing revision and the exam itself.
Absolutely. Keep up the hard work.
And maybe a final thought to leave you with. Considering the high recurrence rate, especially in non-muscle invasive bladder cancer, what future advancements in surveillance, maybe biomarkers or imaging, might dramatically change how we monitor these patients long term? Something to think about.